a normal knee joint. My preferred method does not use Schanz pins, does not use additional cancellous screws, bone grafts very rarely, and most of my frames are not knee spanning, but they are just below knee. This will be a different talk. I won't be showing you what I can do and what I have done. I won't be showing you results, pre and post-operative. I'll show you two short videos and how I do a progressive construct and a prefabricated construct. The first video will be a prefabricated construct on a fracture table. The second video will be a progressive construct without a fracture table. Case 1 is a 37-year-old lady with a high velocity motorcycle injury, and case 2 is a 47-year-old man with a high velocity automobile injury. I'll just do the videos now. 1 minute. I have to, because the videos were not playing, I'll have to take 1 minute. Here we go. This video I will demonstrate the complete procedure of. Am I audible? Is the video clear?
Yes, sir. Perfect, sir.
Dr. Tanveer.
We can hear, sir. Yes, sir. You're audible, sir.
Yes, sir.
Can you hear me?
Yes, sir. We can hear you, sir. You are completely audible. Yes, sir. Clear, sir.
Dr. Tanveer, can you hear me? Is the video clear?
Yes, sir. I can hear you, sir.
Dr. Bari, is my screen visible? You go, no problem. Is my screen visible? And is my audio clear?
Yes, sir. Yes, sir. You are completely audible, sir.
Oh, you're mute.
I can't hear you, Tanveer. Yes,
I can't hear you, Tanveer. Please unmute your audio. Can you hear me? Just show me a thumbs up if you can hear me. Dr. Bari just, good. So back to my video. Good. So now this is a patient who is a lady who has a Schatzker tick 6 type of fracture. And here is a prefabricated construct which I am making the night before in my bedroom. So one is a oval ring, one is a round ring, and one is a 5/8 ring. And this is a prefabricated construct which I have taken measurements on the table and of the opposite limb. And you can see it's a very, very simple frame with a combination of arches, oval rings, and a round ring with appropriate compression elements. The surgery is done under spinal anesthesia. The first part is the calcaneum. The foot is prepared. The calcaneum is cleaned. You can see the motorcycle abrasion. The silencer has burnt that lady's leg. And as you will see the video, you can see that the fracture heals before the skin burn heals. That is less than 70 days. I'm just using a half ring and we are tensioning the half ring, the wire on the half ring, and this half ring is anchored to a fracture table, and then we can apply traction to reduce this fracture. So as we apply traction, we can see that the fracture gets reduced to some extent. We can increase the traction more, and get a better reduction. Then the leg is cleaned and prepared in a standard manner. And I prefer to use disposable drapes, not the green cloth drapes which are autoclaved, but the paper drapes just sterile. And we can see the preparation is very standard from mid-thigh to lower leg. Though we are going to cover the foot and ankle in the drapes, I prefer to drape them as an abundant caution. As an arthroplasty surgeon, I am very cautious about sterility, and you can see very special efforts being taken for sterility, be it Ilizarov or be it my other revision arthroplasty surgeries. As I have using a fracture table, I am using an open book construct. You can see that the open book is closed on the table. The loose nuts are tightened, and we complete this frame. Now this frame makes more sense. It has got two arches bolted on the top. Then it has got an oval ring below. Then it has got oblique supports. And it has got tiny arches for drop wires. And then it has got a complete full ring below. This entire frame weighs only 280 grams because it is a lightweight aluminum frame, and we are just locating the frame in the C-arm to see if it is the correct level. As it is an all-wire construct, we are passing standard smooth wires, non-olive wires, from the medial to lateral, lateral to medial, towards just a little above the fibular head. And these are the reference wires to which the frame will be anchored. We need to pass the mediolateral reference wires on the first and last rings, anchor them to the rings, ensure that there is enough space anteriorly, posteriorly, medially, and laterally, and readjust the frame before passing the olive wires for compressing the assembly. The important lesson in any laser of fixation is that we must always have more space posteriorly than anteriorly. If your assembly is very close anteriorly, do not worry because swelling doesn't happen anteriorly, but the posterior part should be free. Likewise, I am using a 5/8 of a ring so that we can start knee mobilization very early. So these two reference wires in the proximal part are enough to give reference to my frame. In the process of tightening, I have seen that the frame has shifted, and so hammering on the frame moves it back to position. I am using a dynamometric tensioner, which I prefer on most occasions. And if there's no space for a dynamometric tensioner, then I would normally use the Russian method to twist the nut to tension. I seldom use manual tensioners. You can see already the fracture is falling into place, except for a lateral gap which needs to be fixed with which needs to be buttressed with an olive. After the proximal most ring, we go to the distal most ring, and these two reference rings with just mediolateral wires without the anterior-posterior wires will define the basic structure and framework of the Ilizarov frame we are using. Once the mediolateral and lateromedial wires are passed, we can pass the anterior-posterior wires. The video is speeded up so that what has taken me an hour and quarter has been condensed into 10 minutes for the talk. And all Elizabeth surgeons who use an all-wire construct are experts in safe corridors. So we have to avoid all the neurovascular wonders and vital structures, because we have used a fracture table. We cannot flex and extend the knee to relax the posterior quadrant. And you can see that the frame now takes its space. These are the drop wires which will be attached to the drop attachment that has been made already. The olive wires have not yet been started. And here to tension, we have used a straight plate only for pulling the olive wire and compressing the fracture. Now you can see that the drop wire will have compressed the fracture, as you will see in the C-arm image. We have used close to 6 olive wires in the proximal fragment, both mediolaterally and lateromedially. And a small nick is made in the skin to pass the olive wire in and again compress it from the opposite side. After the fracture is compressed, the wire is tensioned from this end to ensure that we have a well-balanced assembly. This lateral view shows the generous amount of space posteriorly, though we have kept the frame quite close anteriorly, because this is the most comfortable position for the patient. This particular wire, we don't have place to use a dynamometric tensioner, so we have used a manual tensioner. Also, we have used the Russian method, and we can see that the fracture is slowly falling into place and the gaps are compressing. Repeated C-arm views, multiple olive wires are the needed hour, and we can see that we can get 0 to 90 degree flexion on the table. This was a preoperative X-ray, and this is a post-operative X-ray. And though that reduction is close to 95% and not 100%, it looks very good in anterior, posterior and lateral views, and I have accepted this reduction. On the 15th post-operative day, the patient has full knee movements, loading of the joint, and the patient is walking very comfortably and already showing good callus. You can still see that her silencer burn on the foot has not healed. But the patient comes walking to my clinic on the 14th, 15th day and is extremely comfortable while she is using a walker and loading the leg as best as she can. Now she is coming into my chamber and she is extremely happy, and the results to me are more satisfactory than any plate. She has come traveling in a car, flexing her knee to 90 degrees. On 45th post-operative day, we can see the fracture is nearing union. From a walker, the patient is ready to shift to a tripod, and as she stays on the second floor, I have already asked her to use the stairs and walk up and down. You can see the smile on her face. You can see the movements of the knee. And it's only now that the silencer burns on her leg are healing. With a tripod, she is doing the stairs. And she's extremely happy with the results. And so are the relatives and attendants of the patient. The frame, that there she is loading the leg fully, and the flexion is near full. 67th post-operative day, less than 70 days, we have dynamized the frame, loosening all the threads all the nuts on the threaded rods, allowing her to telescope it and walk, so that we can know that she is ready for frame removal. Most of my Schatzker 5 and 6 fractures are not kept on the frame for more than 90 days. And very few of my frames are above knee. You can see from the leg burn, silencer burn, the foot silencer burn, that 67 days it has taken for the skin to heal. Already the knee has healed. And with a dynamized frame, if the patient is comfortable in 48 to 72 hours, we can assume that the right time has come to remove the frame. So I hope my recording and the video is visible, because I'm not able to see that happening. But if any problems, I know that my video will be uploaded. That is the final frame after dynamization, and that is her after removal of the frame and movements, her static grace, her knee movements. You can see that the time of healing of the leg wound, of the silencer burn, and healing of the fracture are all within 80 days. And there she is, independently walking with a very mild leg. I have now followed up this patient for 4 years. She has absolutely no knee arthritis, and she is extremely comfortable in her activities. So this was a prefabricated construct for, that is the final X-ray. We can see that the X-ray is satisfactory. Now I will go, the second video is a progressive construct. And again, high velocity trauma. And 1 minute. We can see a CT image that the knee is badly splayed, both on the medial and lateral sides. And 3D CT shows a wide gap between the lateral condyle and the medial side. This is a politician, a VIP from the neighboring state, and was referred to me after a fasciotomy by a local surgeon. This needs a reduction, meaning we need to squeeze the condyles together, flex and extend the knee multiple times. The fasciotomy was very inadequate, improperly done, but fortunately, the patient did not develop a compartment syndrome. Multiple manual reduction attempts have reduced the fracture, except for a very small depression in the plateau. We passed the first smooth wire and then an olive wire and compressed the fragment. This is a progressive construct. And so it has not been done on fracture table. We can see that 2 arches have been bolted to make the proximal part. And I first reduced the fracture. Then I added just 1 single ring with cross wires distally. To reinforce the frame, I added 2 arches, and I could get a close to 90-degree flexion. The fracture is very stable. However, I've used 7 wires in the proximal, 1 ordinary wire and 6 olive wires. And we have got a fairly congruent article reduction. This is the patient who is walking on day 1 post-operative in the ward, loading his leg as best as possible. And this is him on the 15th post-operative day on his visit to my clinic. Again, he traveled in his car, sitting in the back seat, and was very comfortable in flexing his knee to 90 degrees. This is the patient 1 month post-operative, and he is walking with a tripod, but is able to load his leg fully and is able to lift the tripod up and walk unassisted to show me how happy he is walking. And then, as the patient was a little over enthusiastic, he sent me a video driving his own car in 6 weeks. That is the magic of Elizarov, that we encourage function from day one. The frames are not heavy. The patients are encouraged to do their social activities and activities of daily living, and they are allowed to do a full weight bearing from day one. This is the status in 90 days. The patient is able to close to 90-degree flexion, and a time has come for us to dynamize the frame and give him 72 hours to see if the frame is ready for removal. The frame is ready for removal, so we have removed the frame. The wires have not yet been pulled out. We have checked the stability of the fracture. And because there are multiple wires, the patient is a little apprehensive. I am giving a local anesthetic at both exit and entry points so that I can we do not try to struggle to pull the olive from the opposite end. I have given him a single layer protective leg gaiter for 2 weeks for his satisfaction and mine, though this sort of protective cast is not necessary and I do not use them these days. This patient has been followed up for close to 7 years and has done very well, and even now sends me festival greetings. This is more like this is the patient's result in 6 months when he came to visit me. That is his movement, and he's able to sit cross-legged and is able to squat, and he's an extremely happy and satisfied patient. And coming back to our slides, what are the take-home messages? Number one, Elizarov is the best and most preferred method of managing upper tibial fractures. Number two, double plating and metal in such cases and in such superficial area is fraught with complications. The procedure and methods are very easy to learn and well duplicatable by every surgeon, a beginner or advanced. I thank you very, very much for giving me this opportunity, for being in your presence and presenting this lecture. Thank you very much, and I shall stop the screen and hope that you have all been able to see and hear properly. I would like to hear from the faculty if there are any mistakes or errors in my presentation, and if there are any questions, I'll be very happy to take them. Thank you very much. Thanks, Professor Bari and his team, for a wonderful opportunity for me. And thankfully, I have finished in 28 minutes, which is a little lesser than my allotted time. Thank you.
Thank you very much, sir, for your excellent presentation. Now, I would like to request Professor Novikov sir. Novikov sir, can you hear me, sir? Novikov sir?
Yes, I can hear you now. I can hear you. Yes.
Yes, sir. I think Novikov sir can't hear us as because of some sort of network problem is there. Professor Omar sir, can you hear me, sir? Yes, sir. Okay, sir. Then please share your knowledge regarding the presentation, sir.
First question, can I ask you, was that talk clear and audible and the slides go well?
Yes, sir. The slides were
No
excellent.
interruptions?
No interruptions, sir.
Okay,
no interruptions. Absolutely fantastic, sir.
Thank you very much.
Professor Omar sir, do you have any questions or do you have any knowledge sharing regarding the presentation, sir? Professor Omar sir, you have to unmute yourself. You have to unmute yourself. We can't hear you.
Can you hear me?
Yes.
Yes, sir. We can hear you, sir.
What about complications? What about complications? Any complication happen?
I have till now done close to 64 cases of Schatzker 5 and 6. I've used an all-wire frame in all cases, no shunt spins, and used this method only. And in about 8 to 10 cases, I've had a little stiffness of the knee that they cannot do squatting. So it comes up to 90 degrees, a little more than 90 degrees, they are not able to do. There has been no pin track infection, and they are all happy and grateful. Properly done Ilizarov seldom has any complications.
Okay, thank you so much.
Okay, thank you very much.
Congratulations. Congratulations.
Pleasure.
Thank you, sir. Now, I would like to request Professor Mufakkarul Bari sir to share his knowledge regarding the presentation, sir.
Can you hear me?
Yes.
Yes, sir.
Yes, sir.
Thanks, El Prakash, for introducing your experience regarding the Schatzker type 5 and 6. And last part of your lecture, I was out of the scenario. I was disconnected. That's why I could not follow. But your case number 1 that I have seen, you are using all the time, most of the time, prefabricated frame, or you love to do the without prefabricated frame? Which one you love to do? And
actually,
during prefabricated frame, do you face any problem with the apparatus and putting the wires when you are using the prefabricated frame? This is number 1. And do you have any difference between the pre and post? Without prefabricated, how do you feel with this Ilizarov apparatus? This is my question.
Excellent question. Initially, I started doing only progressive construct, which is ring by ring. Then I realized that the surgical time was getting very much prolonged. And in most cases, the end frame was very similar to what I had imagined before I started. So I started experimenting with prefabrication. And I spent a lot of time before surgery in my bedroom thinking and designing the frame. And many times I keep the frame on the patient's normal leg and take an X-ray and look at Siam views also the previous day and do modifications. And I'm always ready to change the frame if needed. So basically, whenever I find that one of the rings is not in the right position, or one of the arches is not in the right position, I will add drop wires and adjust the wires accordingly. So I must bring the frame to the wire, not the wire to the frame. That's the basic Ilizarov principle. So I could realize that if I was using a progressive construct, if I'm taking 1.5 hours to do an Ilizarov surgery, with a prefabricated construct, I was doing it in 45 minutes. So when the time constraint came, as I work in private practice, we pay for the operation theatre by the hour. Likewise, I am getting older, so I get tired after 1.5 hour surgery. So I realized that prefabricated is a shortcut. However, in my lecture, I have clearly said that the original Ilizarov way is a progressive construct. Prefabricated is a shortcut. Prefab is applicable to close to 75% of cases. But 25% difficult cases where we need reduction before the frame application, we have to have a progressive construct. Yes. All Ilizarov purists will use an all-wire progressive construct. Only these newfangled surgeons will use shunt spins and all sorts of fancy gadgets. and SUVs and computer software and all. Old people like you and me are very happy with wires and Elizarov, which gives very good results. Hope that answers your question.
Right.
Thank you. Thank you very much, sir. Sir, do you have any more questions or queries regarding the presentations? Professor Mafakarul Baris, sir.
So, in your first slide, second slide, the writings, what you have written, I agree with you. We must convey our message to the young budding orthopedic surgeons. The Schatzker type 5 and 6, if you go for plating, either buttressing 1 or 2, you'll see 25% infection. It is written in Campbell. And, the AO people, they are still advocating for going for 5 and 6. This is a complex tibial plateau fracture. Elizarov is the best option. My message is, because you are using only the biocompatible thin wires. Either you can use the smooth 1.5, 1.8 or 1 olive wires. And it gives a fantastic result. And the day 1, after day 2 or 3 days, you can mobilize your leg. And compartment syndrome, in case of 5 and 6, the skin abrasion is very common. When you go, you should have to wait for, when you are going for plating, you should have to wait for 5, 6 or 7 days. By this time, the problem arises. That's why my observation, and 5 and 6, even 1, 2, 3, 4, 5 and 6, I as the Elizarov surgeon, initially I did this with the screw, with plating also. Now I love to do with all cases. 5 and 6, obviously Elizarov. And sometimes with this, I can go for plating and screws. So message is, what you have shown today for the young doctors, 5 and 6, better go for Elizarov. Thank you so much.
Always go for Elizarov, not better. Campbell must be changed.
Always go for Elizarov. Yes. Always go for Elizarov. Yes, I am agree.
And if you're not confident, refer. Don't miss up.
If you're not confident, refer it to Elizarov. Exactly.
Yes. That is my message today. That's all.
Yes. Yes.
Thank you very much, sir.
What about the comment of Novikov?
Sir, I think Novikov sir can't hear us, sir, as because of some sort of network problem. He cannot hear us properly. So he cannot reply us.
Novikov. No.
No, sir, he can't, sir.
Oh.
But he has stayed with us and listened to the talk good enough. You can see the recording.
Sir. Yes, sir. Now, I'd like to request Dr. Shamsuddin sir to say something regarding the presentation and sharing his knowledge also.
Thank you, Dr. Tanvir. First of all, I really like to thank Dr. L. Prakash sir for coming and privileging us in our program. And I really congratulate Baris sir and Dr. Tanvir that we are having our 50th series of lecture this day. And it's a real privilege that I'm sitting in front of 3 legends from 3 continents. It's a real great day for us. So, regarding the cases of Elizarov in the Schatzker types, I've been using Elizarov frequently in Schatzker type 5-6 cases because if we have been facing blisters, compound injuries, compartments, even skin grafts, so it gives excellent results and wonderful results. I have 2 questions from my side and 1 question from YouTube, sir. My first question, as I already discussed in our Elizarov group, that it doesn't matter of discussion that in proximal tibia fractures. Sir, Prakash sir, what is your take on use of spanning in the distal femoral ring, sir?
What happens is, our John Charney has always said, when the bone breaks, ligament doesn't tear. When the ligaments tear, bone doesn't break. So if the femur is intact, it's only a tibial fracture, the ligaments are intact. So if you're able to stabilize the tibia, why do you need to span the femur? For your mental satisfaction, and you're going to keep it stiff for 6 weeks, and only for ideological satisfaction, and you make a longer frame. So 95% of my frames in such fractures are below knee. I do not span, I don't use a hinge, and I've never had any laxity. It is very rare to have ligament ligamentous tear as well as bony breakage together.
Thank you, sir. I really agree with you, sir, because I've been not using spanning in any of my cases. It has been a matter of great discussion in our WhatsApp group, but I've not faced any problem with spanning. And my second question is, I've been using in many of cases 5 by 8 rings in the proximal ring, sir. What do you say about that, sir? We should use full ring or 5 by 8 rings, sir?
I can't hear the. Please repeat the question.
So, I have been using in many of the cases of proximal Schatzker. I've been using 5 by 8 rings as the first ring, sir, to avoid knee stiffness, sir. So, what is your take, sir?
I always say that the first ring has to be a 5/8 or a 7/8 ring, where you attach 2 arches and just allow knee flexion. Second ring has to be an oval ring, so that we have got much space in the back. Third, fourth rings can be circular. Ilizarov is like a beautiful toy. Meccano said, you can adjust it and play in whatever way you want. And in that, now this also answers Dr. Bari's question. When you're doing a prefabricated construct, you are doing it at home. You're having a glass of drink or you're watching something and your mind is free. Patient is not there, anesthesia is not there. You can keep on changing till you get a nice final frame. When you're doing in the theater, patient is under anesthesia, assistants are there, everybody is watching you, the clock is ticking, and you have to hurry. So that is why I spend more time in fabricating the frame than the actual surgery. Not much literature is there on advantages of prefabricated frame, but we should do one lecture sometime in future on prefabricated versus progressive construct. And if possible, we'll invite Dr. Muhammad Yunus, who is an expert on prefabricated construct, and we will listen to his talk on this subject.
Thank you, sir. So we have one question from Auto TV YouTube. It is from Dr. Praful Harode, and the same question from Dr. Vimal Kumar Gupta, that what do you do for posterior fragments, posterior medial as well as posterior lateral fragments?
Yeah, that was my question also, sir.
That number one, we reduce. Important key is to keep your thumb on the neurovascular bundle and go adjacent with an olive wire. People are very scared of posterior anterior and anterior posterior wires. Now we know that the femoral nerve comes down and at the popliteal foci spreads and goes down. The anatomy is in our mind. And we can always palpate even the most bulky patient by pushing the thumb. We can palpate the neurovascular bundle to feel the pulsations. And then adjacent to your thumb, if you pass the wire, you're near the vessel, doesn't matter. You won't cause an aneurysm. Most of Ilizarov surgeons are very scared of sciatic nerve and popliteal vessels. But you must be unlucky to hit the vessel. You must be really unlucky to hit the vessel. If I show you some X-rays of my frames, we have got wires directly posterior anterior. Nothing has happened to the patient. He's been so happy. Dr. Bari will agree with me, and in this experience, he would have done this himself. So when a beginner is there, he will be scared that as it is posterior corner, posterior middle corner, posterior lateral corner, vessels bifurcating, that is coming right in a position. Go 1 millimeter this side, go 1 millimeter this side. Right. I have gone right through the popliteal fossa. In the popliteal fossa, there are no vessels because everything is bifurcated. So from popliteal fossa, I can go oblique. Exactly. So we meet let us see the hamstrings come down. And in between go directly, there is no harm. New surgeons are taught shortcuts with chance screws in unidirection, which is through safe corridor. They are scared of wires. Right, these days, I hardly see a single Ilizarov surgeon doing proximal femurs with all wire construct, putting a posterior anterior wire, sitting under the table and drilling upstairs. They're too scared. But Ilizarov is a wonderful machinery. You must learn the intricacies and it will be like magic for you. Does this answer the question?
Yes, sir. Thank you, sir. Thanks a lot, sir. Even I follow the same. I use the mini open, put on wires, use sleeves, and put buttress from the posterior middle fragment with olives, sir.
Exactly. That's much easier because when you're in doubt, make 1 centimeter incision, clear everything, and put the wire properly. There's no harm.
It gives very good buttress. Yes, sir. It gives very good buttress. Yeah. We have
Pleasure.
one more question, sir, from Dr. Muhammad Al Hassan Abdullah. He has asked when and how to assess for ligamentous laxity.
In a Schatzker 6 or 5, you cannot assess ligamentous laxity because the bone is broken. And I think I answered the question previously. We must read Charnley's book on close treatment of common fractures. He says it's a rule in orthopedics that either the ligament is strong or the bone is strong. If the ligament breaks, bone doesn't break. If the bone breaks, ligament doesn't break. And that it has not been proved by cadaveric studies or anything, but that to me has stood true and stood correct all my life. So I can assess the ligamentous laxity after I put my frame and stabilize the fracture. Now, suppose that has happened in 5% cases of mine, 5 or 10% cases. When I fully done the tibial frame, I do the 90-degree flexion, then do medial lateral movements. I find that it is very lax. That case, of course, I do a spanning. That's very rare.
Exactly, sir.
So we can only assess after we put the tibial frame.
Exactly, sir. I've done in 1 or 2 cases that after fixing, we have seen the much of laxity. I've done a spanning ring, sir.
That's what is advised. Even in Ilizra's original book also he says that knee spanning should be done after you finish the tibial work and assess the ligament stability and decide whether it has to be done or not.
Right, sir.
Springer book by...
Yeah.
Yes.
Please.
No, Springer book by Ilizra has not been translated properly.
Right, sir. Right.
And lot of his pearls of wisdom are missing in English. But he has put so many X-rays that by looking at the X-ray repeatedly, you can learn so much and so much. Right. So I have posted our Ilizra's original book so many times, but people have never taken the trouble of reading it from cover to cover. To me, it's like Bible. Even now, I find something new there. Look at all those X-rays, and you learn something fantastic. Where he has passed the wires, how he has passed the wires, and that's the magic of Kurgan.
And I extend the same question to Baris, sir. Sir, what is your take on spanning the knee, sir, in these cases?
Listen, we are talking all the time with Schatzker 5 and 6. Instead of that, you will get Schatzker type 7. What is that? Sometimes you get 6 with avulsion of the intercondylar eminence. Sometimes you'll get that one. And in that cases, even 6, I personally go for always fixed with the lower end of the femur for few days. For few days. Few days, how many days? 3 or 4 weeks. And 5 and 6, I keep 2.5 and 3 months. 2.5 and 3 months. By this time, you will get a very good regenerate bone. And consolidation will be very fine. And Schatzker type 6, and El Prakash rightly said, when you are getting bone fracture, the laxity, you will not be able to, identify where is the laxity. And while your ligaments are intact, your bone is fractured or not. While your ligaments are intact, bone is not fractured or bone is fractured. So in this situation, sometimes I go for fixation of the lower end of the femur and of course the upper end of the tibia. This is my opinion. Okay.
Thank you, sir. Thanks a lot, sir.
Thank you. Thank you very much, sir. Thank you, Dr. Shamsudar, sir, for a nice discussion and nice questions there. And I would like to thank Professor Mafakarul Bari, sir, always helping us to arrange this type of academic program. And this is a great day for Orthopedic Solution Academy, as because of this is the 50th program of Orthopedic Solution Academy. And this is a virtual academic platform where we can share our knowledge, where we can gather our knowledge, and definitely from different continents. Many participants are participating in our academy, and that's a great thing, as because of knowledge has no boundary, and we can knowledge from each and every corner of the world. And now I would like to thank today's honorable speaker, as because of he is the 50th program speaker of our Orthopedic Solution Academy, Professor El Prakash sir. It's a great day for all of us, and I would like to thank Professor Omar sir, Professor Ravikant sir, Dr. Shamsudar sir, and definitely the legendary Elizabeth Surgeon of Bangladesh, Professor Mofakharul Bari sir, for being with us. I'd like to thank Rajtubi for helping us for arranging this type of academic program, and definitely Rada Pharmaceuticals Limited for sponsoring our program. I'm Dr. Mohammad Tanvir Ashraf saying bye-bye today. Hope we'll connect to in the coming Friday with another magical Elizabeth topic. Till then, I'd like to say bye-bye to all of you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.